Hello, my name is Quentin Broussard. I'm Assistant Professor of Clinical Sciences and Critical Care at California Health Sciences University, and today we'll be talking about acid-base disorders. The reason that we're talking about acid-base disorders is that they're commonly found in patients in the emergency medicine arena as well as intensive care, and many acid-base disorders, as we'll come to talk about, involve medications as a cause, or potentially medications to treat the underlying acid-base disorder. And it's important to treat these acid-base disorders promptly to minimize morbidity and to prevent mortality. So as a pharmacist, it's important to be aware of the different causes of acid-base disorders so that we can develop treatment plans to focus on the underlying etiology of the acid-base disorder. Our objectives today will be to review the pathophysiology associated with acid-base disorders, so essentially how these acid-base disorders come about. We'll identify acid-base disorders via patient presentation. On day 2 of this talk, we'll focus more on utilizing arterial blood gases and serum chemistries to diagnose acid-base disorders. And today we will develop therapeutic plans to manage acid-base disorders. So essentially we'll be going and focusing mainly on objectives 1, 2, and 4. And we'll save objective 3 for day 2 of our acid-base talk. So to start out, we'll start with a patient case. FM is an 82-year-old male presenting to the emergency room, initially with ultramental status. His medical history is significant for end-stage renal disease, for which he receives hemodialysis 3 times a week on Monday, Wednesday, and Friday. His last dialysis session was 6 days ago. Based on his presentation, which of the following does FM most likely have? Hepatic encephalopathy, hypoxia, uremia, or a urinary tract infection. To follow up with FM, based on FM's presentation, which of the following acid-base disorders does he most likely have? Is it metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis? And finally, which of the following interventions should be administered to correct FM's underlying acid-base disorder? Furosemide, hemodialysis, mechanical ventilation, or sodium bicarbonate. So after our talk today, you should be able to confidently answer all 3 of these questions. Just to get us started, in terms of acid-base disorder, it's important to understand the underlying chemistry of acids and bases. So thinking back to our general chemistry backgrounds, acids are substances that donate protons. So, for example, like hydrochloric acid, or HCl. Hydrochloric acid eventually breaks down into hydrogen as well as chloride. Another acid that exists is carbonic acid, as we see here, H2CO3. And it breaks down into H plus and HCO3 minus. So this carbonic acid is donating one of its hydrogen ions, or hydrogen or plus, or hydrogen 1 plus, depending on which way you like to term it, to eventually dissociate out, and that can go and associate itself with other things in solution potentially. Now, thinking on the converse side of acids, we have bases. First one we'll talk about is ammonium specifically. Ammonium can accept protons, so NH3 can accept a proton to become NH4 plus. Similarly, bicarbonate can accept a hydrogen ion to become carbonic acid. So realizing which substances will accept protons and donate protons is important in the understanding of acid-base disorders, because that is essentially what the underlying pathophysiology of some of these disorders will be. In terms of our bodies, we'll be focusing a lot on the carbonic acid as well as hydrogen ion pathways that we'll talk about a little later in terms of the body. And those will essentially be our buffering systems for acid-base disorders. In terms of acid-base calculations, some of the common calculations that you might see associated with acid bases are pH. And the first one we'll talk about is pH is equal to the negative log of the hydrogen ion concentration, as well as pH being equal to the pK plus the log of the concentration of the base over the acid. So if you remember back to general chemistry, these equations were true, and generally this second equation, also known as the Henderson-Hasselbalch equation, is true for buffered solutions of weak acids and weak bases. And essentially in this body, you have a buffering system that will help to buffer the pH to a normal physiological level. Now, it's not important to necessarily know these equations because you won't be tested on these equations, but just know the underlying concepts of what affects pH. And that is essentially the concentration of the acids and the concentration of the bases. So in terms of our body does a lot of buffering, and what buffering is defined as it's the ability of a weak acid and its corresponding base to resist change in pH of a solution on the addition of another strong acid or base. So what we'll see in a lot of these acid-base disorders that we're talking about is that there's some kind of addition of an acid or an addition of a base, or even a removal of an acid or removal of a base that will eventually affect a patient's pH level in their blood. And whenever you have those alterations occurring, your body would like to ideally stay between an ideal pH range of around 7.35 to 7.45. It's happiest being at 7.4. Whenever it goes out of those ranges, your main physiological buffering system of the carbonic acid and the bicarbonate system, so that H2CO3 as well as the HCO3- that we were talking about earlier, comes in to play a role in trying to adjust the body's pH, regardless of the addition or the removal of strong acids or strong bases. There are some other buffer systems in the body that try to adjust acid-base balance, such as plasma proteins, hemoglobin, and phosphates, but these are much smaller players than the main physiological buffering system of the carbonic acid and the bicarbonate. To give you an idea of how this works specifically in the kidneys, I understand that this slide is very, very busy, but just to give you an idea, in the kidney you have your tubules, and whenever your kidneys are filtering different substances, one substance that they filter out is this bicarbonate ion here. And that bicarbonate ion can be combined with a hydrogen ion to make carbonic acid, as you see here. The carbonic acid then can be changed by carbonic anhydrase, which is an enzyme, to eventually go into water plus carbon dioxide. Now, that water can be reabsorbed back into the peritubular capillaries and back into systemic circulation, but that carbon dioxide can cross into this renal tubule cell here and combine with water in converse to it being split apart here, and it can combine back in with carbonic anhydrase to form a hydrogen ion and a bicarbonate ion. So essentially we're reproducing what we had here at the beginning. And what's limiting this is that sometimes things can't cross over necessarily through the tubule cells or the brush border membrane. This hydrogen ion goes back and gets reused in the tubule lumen or secreted back into the tubule lumen. So essentially the path of the hydrogen ion keeps going in circles counterclockwise. But that bicarbonate ion can actually go back into systemic circulation and be reclaimed or reabsorbed. And that is one of the main underlying things about acid-base disorders, is that bicarbonate functions as our base in our body that is helping us to maintain physiological pH. Now, whenever your bicarbonate becomes too high or too low, your body has to compensate for that. And the compensation that will get done is actually in the lungs, where we have CO2. Remember, CO2 is what gets breathed out after we breathe in oxygen. We're essentially exchanging oxygen for CO2. So bicarbonate is our major base, and CO2 in the lungs is our major acid. So whenever you think of base, think bicarbonate and the kidneys. Whenever you think of acid, think about the lungs and about CO2. To kind of follow up on our talk about physiological regulation of acid-base disorders, for normal respiratory function, typically we see patients have a PaCO2, or some people might call it a pCO2. So you might see throughout this presentation that PaCO2 and pCO2 are used interchangeably. They're the same thing. That this pCO2 level is actually around 40 millimeters of mercury. And that's essentially representing carbon dioxide that's produced metabolically, as well as carbon dioxide that's lost due to respiration. And the carbon dioxide that's being produced metabolically is a result of all of the different biochemistry pathways that we see. Whenever you think about people taking in volitional intake with food, a lot of our carbohydrates are essentially carbon-based, and that carbon can actually help produce carbon dioxide, which can eventually be breathed off. Now, in terms of our renal function, with bicarbonate specifically, our normal bicarbonate level was around 24 milliequivalents per liter, and a normal pH is around 7.4. So your lungs are essentially trying to act together with your kidneys to maintain this optimal pH of 7.4 here. So when these numbers start going higher or start going lower, the other organ has to try to compensate for what the other organ is doing. So say if the lungs are adjusting, then the kidneys have to respond to whatever the lung adjustment is. So it's kind of a constant balance here, as we see here with this pH scale on the right side. It's a constant balance between acids and bases. However, in the body, your normal pH is 7.4, not 7 as we would normally think in a general chemistry sense. So keep that in the back of your mind. For normal blood gas values, and a blood gas is essentially what we take to assess these different parameters, we focus mainly on arterial blood samples. These arterial blood samples have a variety of different parameters that are measured. So for pH, as we said, the normal pH is 7.4, and it can range from anywhere from 7.35 to 7.45. PO2 is another parameter that we may look at, and it ranges from 80 to 100 millimeters of mercury. We have SaO2, which is arterial oxygen saturation. Ideally, we want it to be greater than or equal to 95%, though some people will accept it being at least 90%, and that's acceptable as well. This PCO2 or PaO2 is a value that we commonly associate with the lungs. So that's the amount of carbon dioxide, or the pressure of carbon dioxide in the lungs, and that is between 35 and 45 millimeters of mercury. As we said before, the normal value is around 40. And bicarbonate, which we commonly associate with the kidneys, the normal value is around 24, but can range anywhere from 22 to 28 to be normal. So it's important to keep all of these values in the back of your mind whenever you're looking at an arterial blood gas. And these will be numbers that you do need to know for examination purposes and in practice. Now, the mixed venous blood gases are a little bit different. As you can see here, they have some similar ranges for some of the parameters like the pH as well as the bicarbonate. But in order to be validated and accurate, you should be using an arterial blood gas, as that's what we measure acid-base disorders off of primarily. If you're using a mixed venous blood gas and pulling the blood from a vein instead of an artery like the arterial blood gas, you will yield different results. So that's important to keep in the back of your mind. If you do have a mixed venous blood gas, you may see alterations in some of these numbers that you see here. A little bit more about how they actually take these arterial blood gases. They'll utilize a tool called an arterial line. So an example of an arterial line is seen here. This arterial line is placed radially in the patient's wrist area. And you have different transducer systems as well as different flushing systems that help to regulate this. And then all these eventually wire up to a monitor where you might see an arterial waveform. Commonly, arterial lines are used for monitoring blood pressure in intensive care, but you can also take blood samples from these lines as well that you can send to the lab and then get an arterial blood gas result as you see here from. So this is essentially applying the patient to the lab that you see here. Just to review the terminology of acid-base disorders, anytime that we say respiratory, we'll refer to the lungs. Whenever we mention metabolic is typically a term that they use for anything but the lungs, and for our purposes, we'll associate that with the kidneys. As we mentioned before, acid-base disorders are a balance between what the kidneys and the lungs do to regulate pH. So what one organ does, the other has to compensate. So say if you have a underlying acid-base disorder that is respiratory based, your kidneys will have to compensate for your respiratory disorders. And that can take at least 24 hours to compensate fully. Though the compensation will begin probably around the 6-hour mark, it does take kidneys a while to work. That full compensation probably will not be seen until 24 hours after. Versus whenever you have a metabolic disorder or some kind of kidney issue going on that's causing the acid-base disorder, where the lungs will compensate. And whenever you think about lungs are essentially organs that are causing breathing for us, so they will compensate immediately, versus the kidneys, which will take a little bit of time. And typically what the lungs do to compensate is you'll breathe faster or you'll breathe slower. Commonly, the substance that we associate with the lungs is the carbon dioxide or the CO2, and with the kidneys we associate the bicarbonate or the HCO3-. So taking that terminology that we just talked about, now we'll list the different types of acid-base disorders that exist. And those are metabolic acidosis, and that is subdivided into anion gap and non-anion gap, and we'll discuss what those are in a moment. Metabolic alkalosis, a respiratory acidosis, a respiratory alkalosis, and then we also have something called mixed disorders, which mixed disorders can be combinations of any of the above disorders: metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis. So it's important to remember that some disorders that you may see are mixed. For the objectives of this talk, we're going to focus primarily on identifying a primary disorder, and then we'll also focus eventually, once we get toward the end of our day 2, we'll start talking a little bit about mixed disorders and how to identify if a mixed disorder exists. In terms of treating these acid-base disorders, it's important always to treat the underlying etiology. So if a patient comes in and they have some underlying problem that's causing an acid-base disorder to occur, then that underlying problem should be treated or minimized as best as possible. Now, some of the causes of acid-base disorders, as we'll see, are not necessarily things that we can cure, but we can try to minimize to the best of our ability in terms of acid-base variation as well as pH variation. So the first disorder we'll talk about specifically is metabolic acidosis. So remember, metabolic means the kidneys, acidosis means that there's some kind of acidosis occurring. So ideally, it tends to be characterized commonly by decreased pH or acidosis, secondary to decreased serum bicarbonate. So again, think the kidneys. And this results from adding organic acid to the extracellular fluid and accumulation of endogenous acids, likely secondary to impaired renal function or a loss of bicarbonate. So if you think about the first two reasons are reasons why you become more acidotic. You're essentially adding more acid into the patient's circulatory system. And if you add more acid, you become more acidotic. However, you can also become acidotic by losing base from a system as well. So it's important to keep that in the back of your mind, that it can either result from additional acid or loss of base. Now, for metabolic acidosis, the compensation for this will be an increase in the respiratory rate. So think about our lungs. Our lungs are what are housing that CO2 that is our body's endogenous acid. So whenever you have an acidosis coming from other sources that we mentioned here, what our body's going to try to do is we're going to try to breathe off that acid in the form of CO2 from the lungs. And that will help to reduce our acid load overall from the body and to make our body more basic or more normal, at least in this sense. And that's represented by a decrease in the PCO2 value. So a lot of times what you may see is that the PCO2 normal range, or the PaCO2 normal range, is between 35 and 45 millimeters of mercury. You may see it go down below that 35 to 45 in order to compensate for what the abnormality related to the kidneys is. There are two different types of metabolic acidosis. There's an anion gap and a non-anion gap. And we'll talk about those briefly. So first of all, we need to talk about what an anion gap is. An anion gap is the difference between the serum sodium concentration and the sum of the chloride and the bicarbonate concentrations. An anion gap is characterized by your sodium concentration minus your bicarb minus your chloride, essentially, whenever you put it in a mathematical equation. For patients who have normal anion gaps, their anion gaps tend to be around 9 milliequivalents per liter, but that can range anywhere from 3 to 11 milliequivalents per liter. And to be considered an elevated anion gap, it should be at least 12 milliequivalents per liter. So this equation will be important to know so that we can calculate an anion gap based on the patient's serum chemistries. Now, if their anion gap is high, they may have an anion gap metabolic acidosis, versus if they don't, then it will be a non-anion gap. Now, this illustration here shows you what essentially that anion gap is compared to your other ions. So it's essentially basically the difference between most of your positive ions, which sodium makes up most of your positive ions in your serum, as well as potassium, but potassium is much less, and sometimes it's not calculated out. But what our body's goal is to maintain an equal number of cations, or positive ions, and anions, or negative ions. So this anion gap can influence essentially our acid-base balance. And whenever we talk about the gap and non-gap, we'll talk about the way that that changes, as you see in illustrations B and C here. So the important thing to remember about anion gap is it's essentially an anion sum of all of the other smaller anion quantities in the body. Now we'll talk about anion gap, or AG, metabolic acidosis. So this is commonly associated with that anion gap level of at least 12 milliequivalents per liter. So ideally we want that anion gap to be at least 12 or more. And it's commonly caused by additions of organic acids to extracellular fluid or accumulation of endogenous acids, and that's likely secondary to impaired renal function. So the way I like to remember anion gap metabolic acidosis is that it's commonly caused by some kind of toxin or something that is not supposed to be there in the quantity that it's supposed to be in. So for example, we'll talk about uremia in a little bit, but uremia, or uric acid, has a small role in our body. However, when that uric acid starts to accumulate, it can become a toxin and can cause different encephalopathies to occur, and that can actually be dangerous. In terms of anion gap metabolic acidosis, as you see here, you have a much larger anion gap versus your normal anion gap. You'll have a decreased bicarbonate, which is characteristic of any metabolic acidosis that you see, and typically around a normal chloride, though this won't always be the case, so it's always important to calculate your anion gap. For different anion gap metabolic acidosis causes, those can be summarized by the acronym MUDPILE. So if you look to the left here, I've bolded each letter of the beginning of each of the different causes. They spell out MUDPILEs. So different acidosis causes metabolically are methanol or metformin, uremia, as I mentioned, with patients who have kidney disease. They may accumulate uremia or uric acid. For diabetic ketoacidosis, the toxin here is essentially ketones that gather up in the body as a result of being at hyperglycemic states. Propylene glycol and paraldehyde are also commonly seen. Propylene glycol is a solvent that's found in many different IV solutions, such as Ativan or lorazepam drips that you may see used for sedation. And paraldehyde is another name for acetaminophen. Infection, isoniazid, and inborn errors of metabolism are the I. So infection can cause a metabolic acidosis that's anion gap through potentially causing intervention galactic acidosis from sepsis. And sepsis is essentially an inflammatory syndrome where infection has gotten out of control and the body can't necessarily compensate anymore by itself. Inborn errors of metabolism may occur when patients are not able to properly metabolize different toxins as well as byproducts in the body, and those byproducts can accumulate in the body and eventually cause toxic side effects such as encephalopathies, multi-organ failure, etc. Lactic acidosis is probably the most commonly seen anion gap metabolic acidosis, and it's seen mostly with patients that have sepsis or a pretty severe infection. The treatment for that is to treat their underlying disorder, which is the infection. So prompt administration of antibiotics as well as fluids for patients who are hypotensive is important. Ethylene glycol and ethanol are another source of metabolic acidosis, as well as salicylates or things such as aspirin, as a lot of these substances are acidic in nature. So a patient may potentially overdose on aspirin and not be able to eliminate it as well, and they may develop an anion-gut metabolic acidosis as a result of that, though that's probably more commonly seen in overdoses. For non-anion gut metabolic acidosis, it's commonly associated with an anion gap less than 12. And it's caused by the same things that cause the anion gut metabolic acidosis, in addition to loss of bicarbonate or loss of base, which produces that acidosis. As you see here in illustration C, this is a metabolic acidosis that's due to bicarbonate loss. So if you're having decreased bicarbonate, you have potentially elevated levels of chloride to compensate for that from the anion side, because remember, we still have to keep equal amounts of anions and cations in our body, as well as a little bit smaller of an anion gap. It doesn't appear that the anion gap compensates as much compared to the chloride. In terms of causes of non-anion gut metabolic acidosis, those include Durham, or D-U-R-H-A-M. Those are listed as diarrhea, which can cause a metabolic acidosis as a result of losing bicarb from the lower GI tract. Ureteral diversion and pancreatic fistula, because sometimes you can lose bicarbonate through these methods. A fistula is essentially something that is leaking, or it's a disconnection of something particularly in your GI tract, which is not supposed to be disconnected. And through those little disconnections, you can have leakages. Renal tubular acidosis, which is a type of kidney disorder that's caused by antibiotic agents as well as some other causes, can cause a non-anion gut metabolic acidosis. Hyperalimentation, or overfeeding with TPN, total parenteral nutrition, as well as saline resuscitation. So if you think about what TPN and saline include, those include chloride-rich solutions. And chloride is one of those other substances in the body that can influence acid-base balance, as chloride is one of our endogenous acids. Acetazolamide and Addison's disease can also cause a non-anion gut metabolic acidosis. For acetazolamide specifically, it is a diuretic, and the way it causes this acidosis is actually through dumping bicarb, which is why you'll see it used a lot in patients who need to go to the mountains for trips, who may develop altitude sickness. Essentially what happens is these patients start hyperventilating, they get a respiratory alkalosis, and to compensate for that they are given acetazolamide to compensate for respiratory alkalosis by generating a metabolic acidosis, so that essentially it'll equal out. And then you have different miscellaneous causes, which we won't go into too far in depth, though your review article that you'll read may go into some of these, as well as the mechanism behind them. The next type of acid-base disorder we'll talk about is metabolic alkalosis. And it's characterized commonly by increased pH or alkalosis, secondary to increased serum bicarb. So again, think the kidneys, because it is metabolic. So that increased pH is as a result of high bicarb levels or high base levels. And it results from the loss of hydrogen ions from the GI tract or the kidneys, or addition of bicarbonate. So essentially addition of base with addition of bicarbonate, or loss of acid from the GI tract or kidneys. Typical compensation for a metabolic alkalosis is a decrease in respiratory rate. And whenever you decrease your respiratory rate, you're actually retaining more carbon dioxide, and you're increasing that pressure of carbon dioxide, or PCO2 or PaCO2. There are two different types of metabolic alkalosis, and those are the chloride responsive and the chloride resistant. We won't go too far depth into what each of those is specifically, like we did with the anion gap, metabolic acidosis, and non-anion gap. But it is important to note that a urine chloride of less than 10 milliequivalents per liter will signal a chloride responsive metabolic alkalosis, and a urine chloride greater than 20 will essentially represent a chloride resistant metabolic alkalosis. And those are used to guide the treatment of some of these different metabolic alkalosis etiologies. For the different causes of metabolic alkalosis, contraction or dehydration is one thing that can potentially stimulate a metabolic alkalosis. And this is essentially done through dehydration, though sometimes you may see it done through different diuretics used. Diuretics, especially those that are continuous infusion, can cause dehydration and essentially this contraction metabolic alkalosis. Sometimes it's through loss of hydrogen ions specifically. Licorice can also cause a metabolic alkalosis, and it's not like the licorice that you see here, like Twizzlers. This is actually more along the lines of licorice, the herb, or the root. Different endocrine disorders such as Cushing's disorder can stimulate a metabolic alkalosis, as well as vomiting or GI loss. And with vomiting and GI loss, essentially what you're vomiting up is you're vomiting up hydrogen ions, because hydrogen ions are found in our gastrointestinal systems, particularly on our stomach, and those are the things that help digest different foods, as well as to prevent growth of bacteria in our GI tract. Excess alkali or excess base, such as antacids, can cause a metabolic alkalosis. Different renal disorders, such as Barter's disorder, as well as hypokalemia, can cause metabolic alkalosis. Patients who are post-hypercapnic may develop a metabolic alkalosis, and the reason why that they develop this is if patients are hypercapnic, they're retaining CO2, and those patients will essentially have a respiratory acidosis, which we'll talk about shortly. To compensate for a respiratory acidosis, your kidneys will want to compensate by generating a metabolic alkalosis, so they will want to increase base so that they can minimize the impact of that acid in the lungs. And then, as I mentioned before, diuretics can also cause metabolic alkalosis, which is associated with contraction that you see up here. However, that does not include acetazolamide, as we talked about acetazolamide in our non-anion gap metabolic acidosis. So that's important to note. Other diuretics, though, such as Lasix, furosemide, or Bumex or bumetanide, particularly whenever they're in drips, can cause metabolic alkalosis. So if a patient is having to be diuresed because they're extremely fluid overload, they may develop a metabolic alkalosis. The next topic we'll talk about is respiratory alkalosis. And it's characterized commonly by increased pH secondary to decreased PCO2. So think the lungs. Increased pH corresponding with alkalosis, and PCO2 going on with the lungs, which is respiratory. And this can result from increased neurochemical stimulation. This can be through your central or peripheral nervous systems, as well as physical increases in ventilation via voluntary or artificial means. And those artificial means will include things such as mechanical ventilation or CPAP mask. Our compensation for respiratory alkalosis is to compensate with the kidneys, as the primary disorder is associated with the lungs. And with the kidneys, since you have an alkalosis, decreasing the bicarb will make you more acidotic. And now remember that compensation will take at least 24 hours to fully kick in, though it may start kicking in slowly around the 6-hour mark post the initial insult. For respiratory alkalosis, there's not necessarily a great acronym for this. The acronym is CHP, and if you actually go back to the metabolic alkalosis, the acronym here is clever PD. So going back to CHP, if you think about different things that can get rid of carbon dioxide, particularly patients who are very hyperventilatory, where they're getting rid of lots of CO2, those are typically the things that you see commonly associated with respiratory alkalosis. So in terms of central stimulation of respiration, you may see anxiety, pain, fever, pregnancy, or even medications. And these things are essentially stimulating your lungs to breathe quicker or hyperventilate. You're breathing off more CO2, and as a result, you become more basic, and that generates this alkalosis. And because it's respiratory based, it's respiratory. As we talked about earlier, high altitudes can also cause respiratory alkalosis associated with hypoxemia or tissue hypoxemia. Pneumonias can also cause patients to hyperventilate, as well as patients with severe anemia. So extremely low hemoglobin values can cause patients to hyperventilate and want to strive to get more oxygen in their systems. In terms of the P, peripheral stimulation of respiration, a pulmonary embolism or asthma can also stimulate respiration. Now, these two syndromes particularly, as well as pneumonia, may not necessarily go along with just respiratory alkalosis, but sometimes they can slow down the respiratory drive too. So it's important to assess the whole patient to determine whether or not this will be a respiratory alkalosis or an acidosis. Because in terms of the alkalosis that we're talking about here, these patients are probably hyperventilating as a result of the insult that has happened to their lungs. Versus respiratory acidosis, where we primarily see patients having decreased pH secondary to increased PCO2 or PaCO2. So again, think the lungs. Decreased pH corresponds with acidosis. And this can result from anything essentially causing CO2 retainment, and that can be inhibition of the respiratory center or restriction of ventilation, airway or pulmonary abnormalities, neuromuscular abnormalities, as well as mechanical ventilation issues or mechanical ventilation problems. Now, it's not important necessarily to know how exactly mechanical ventilation works, but sometimes mechanical ventilation settings, particularly in the intensive care unit and sometimes in the emergency department, may be set to where patients aren't adequately ventilating out the CO2 that they have in their lungs. And that's what's causing this acidosis to happen. Now, whenever we have a respiratory disorder, remember that our compensation is associated with the kidneys, and for an acidosis, we'll want to compensate by increasing the bicarbonate level or increasing HCO3-. And this can take up to 24 hours to fully take effect. In terms of respiratory acidosis causes, they are represented by the acronym ENCAMP, E-N-C-A-M-P. So enteral and parenteral nutrition can cause a respiratory acidosis through the generation of CO2. Remember, as we talked about earlier, that nutrition and different macronutrients can be broken down essentially into carbon, oxygen, as well as hydrogen. So a lot of times whenever you're overeating, or if you have a really big meal, you're generating a lot of CO2 and water, and that CO2 has to be eliminated through the lungs. So if you're eating too much, you may have too much CO2 and that acidosis may actually develop. Some neuromuscular junction disorders may cause a respiratory acidosis, such as Guillain-Barré syndrome, myasthenia gravis, as well as brainstem or cervical cord injuries. And all of these are really essentially related to a paralyzing of lung function, which may not cause the lungs to actually function the way they're supposed to breathe off that CO2, and that's why you get an acidosis. Some central causes of respiratory acidosis include medications, such as sedatives and opioids that cause respiratory depression. And whenever you cause respiratory depression, you're essentially retaining a lot of CO2 because you can't breathe it off. Also, patients in status epilepticus who may not be able to control their breathing adequately may develop respiratory acidosis, as well as those with head injuries. Airway and pulmonary abnormalities are a really common cause of respiratory acidosis, and those include obstructions, so something obstructing the lungs to where CO2 can't exit, asthma or COPD, so you see asthma again here, pneumonia, in terms of patients who are not able to eliminate that CO2 properly, as well as acute respiratory distress syndrome, or ARDS. And this is another type of syndrome where you're in respiratory failure. Mechanical ventilation, depending on your settings of mechanical ventilation, particularly if you're retaining a lot of CO2 as a result of that, can cause a respiratory acidosis, as well as different perfusion abnormalities, such as a massive PE, which may prevent breathing from occurring, or even cardiac arrest. So just to get an idea, this is a chart that breaks down the different acid-base disorders based on their pH, as well as the primary disorder. So remember, if we have an acidemia, our pH is going to be less than 7.35, and that's going to be either as a result of increased CO2 in the lungs or decreased bicarb associated with the kidneys. And those will generate a respiratory and a metabolic acidosis, respectively. Alkalemia is pH greater than 7.45, and it's associated with decreased PCO2 or increased HCO3-, and those generate a respiratory alkalosis or a metabolic alkalosis, respectively. There are some different tools you can use in terms of trying to identify these acid-base disorders. As you see here, a lot of them are actually wider left off. And these are some of the methods we'll talk about more on the Day 2 material. But in terms of the ones that you can use from today's lecture, well, we've talked about patient presentation, particularly with the different causes of these acid-base disorders, and we've talked a little bit about serum chemistries, particularly with the anion gap. And those are things that you can use to help distinguish some of the acid-base disorders. We'll talk about more about these others on Day 2. We'll also explain why there's a picture of the Colosseum here, because it actually goes along with one of the potential tools. These are the references. And we'll go back to the patient case that we talked about at the beginning. So we have FM, our 82-year-old male, came to the ED with altered mental status. He has ESRD, for which he gets hemodialysis 3 times a week. And his dialysis session was last done 6 days ago. Based on his presentation, which the following does he most likely have? The answer here is uremia. So if you remember during the presentation, uremia can be associated with decreases in renal function, and if you're not getting your dialysis at appropriate times, so this patient should be getting their dialysis at least every 2 to 3 days based off the Monday, Wednesday, Friday schedule, but he hadn't gotten it in 6 days. So as a result of not getting it in 6 days, that can cause accumulation of your different toxins in your body to accumulate, such as uric acid, and that can cause a uremia. It's not hepatic encephalopathy because the liver isn't involved. Now, in terms of hypoxia, Patients may develop, hypoxia because of this. Um, if you think about the underlying condition and the compensation by the lungs that has to happen, you're having to breathe off a lot of CO2 and you potentially are hyperventilating. So hypoxia could potentially happen, though it's not clear from this case that actually is happening. Uremia is the best answer here, and the patient does not have a urinary tract infection. Based on his presentation, which of the following acid-base disorders does FM most likely have? The answer here is metabolic acidosis. So if you remember, uremia is actually a cause of anion gap metabolic acidosis as a result of the accumulation of uric acid. And it's more associated with the kidney, therefore it's metabolic. Which of the following interventions should be administered to correct FM's underlying acid-base disorder? The answer to this question is hemodialysis. So if you remember what the different causes of acid-base disorders are, and the things that can correct those different causes, that is the intervention that you want to do. So you want to correct the underlying cause. For FM, he hadn't had dialysis in 6 days, so if you give him dialysis, his acid-base disorder will likely resolve as a result of clearing out that uric acid via HD. If you have any questions, feel free to email me. Please read the associated review article that is listed in your readiness material, as it will provide a lot more detailed explanation regarding the different pathophysiologies associated with these acid-base disorders. Thank you and have a good day.